السلام عليكم ورحمة الله جميعا. أهلا وسهلا بكم، وكل عام وأنتم بخير مقدما بمناسبة قرب شهر رمضان الكريم. Welcome dear colleagues and friends. On behalf of the Pan-Arab Association of Radiological Societies, I would like to thank you all for joining us tonight in our first webinar titled Cardiothoracic Imaging. The webinar will be in collaboration with the Radiological Society of Saudi Arabia. It will be moderated by Dr. Tomadur Gazzaz, a distinguished cardiothoracic radiologist from Saudi Arabia, and will be given by the distinguished speaker, Dr. Diya Hakim, from the Brigham and Women's Hospital, Boston, USA. This will be the first webinar of a series of webinars and other activities that we've planned for this year, covering different subspecialties in radiology. We have, for example, as you see in the screen, we have a webinar about prostate imaging coming up in May, another one about women imaging in October, and then a webinar for the radiographers. We also have the AI second Paars Artificial Intelligence Forum, which will be held in Dubai in collaboration with the Radiological Society of the Emirates, and this will be in September. And we have a workshop taking place in Egypt in June, and this will be about neuroradiology. We also have our annual conference taking place in Saudi Arabia in collaboration with the Radiological Society of Saudi Arabia, and that will be end of October, inshallah. So we actually, it will be our pleasure to have you all joining us in our upcoming activities. And now I will leave the floor to Dr. Tomadur Al-Gazzaz, as I mentioned, is a consultant thoracic and pediatric cardiac imaging radiologist at King Faisal Specialist Hospital and Research Center in Medina. Dr. Tomadur will introduce our distinguished speaker, Dr. Diya, and will moderate the webinar. Thank you so much.
Thank you, Dr. Lamia, for the invitation to moderate this session, and congratulations on the first wave of Paars. We are excited, and it's about a topic in cardiothoracic radiology. Without any further ado, I would like to introduce our speaker, Dr. Diya Hakim. Dr. Hakim is an interventional cardiologist, and he's the director of the Intravascular and Cardiac Imaging Core Laboratory at Brigham and Women's Hospital in Hartford, USA. Dr. Hakim will talk about a comprehensive approach to coronary CT angiography, including theoretical and practical part. I would like to mention that there are a space for questions, so please send us your questions and we will address them to Dr. Hakim. And now, Dr. Hakim, please, we cannot wait to learn from your expertise.
Thank you, Dr. Tomadur. Thank you, Dr. Lamia, for the kind invitation, and for the Pan-Arab Association of Societies for Radiology and for the Saudi Radiology Society. I'm delighted to be with you today. And my name is Diya Hakim. I'm from Brigham and Women's Hospital, Harvard Medical School, and I'm an interventional cardiologist and cardiac imager. And I hope that today our webinar will be the productive start for a series of educational webinar under the prestigious supervision of Dr. Lamia and Dr. Tomadur and the other faculties. So without further ado, I'm gonna share my screen. And sorry, excuse me. As Dr. Lamia and Dr. Tomadur said, that's our topic today is the comprehensive coverage of the coronary computed tomography angiography in evaluation of and treatment of coronary artery disease. I don't have any disclosure for this talk. And as you know, now coronary computed tomography angiography became the imaging modality of choice for evaluating the presence of coronary artery disease. And CCTA used to rule out coronary artery disease. It has a substantial diagnostic and prognostic role in evaluation of coronary artery disease. And CCTA-derived plaque quantification, quantitative and qualitative analysis was related actually to plaque development, destabilization, and future MACE. And adding the physiological index of ischemia, or CT-FFR, made CCTA an excellent test for both anatomical and physiological evaluation of coronary artery disease. So our learning objectives for tonight's webinar will be to discuss how CCTA can be used as a diagnostic modality for clinical assessment of stable chest pain as a possible cause of coronary artery disease, and the role of CCTA in prognosis and management of coronary artery disease, and new cardiac CT techniques, including the role of AI-based softwares. Firstly, you are a distinguished imager, radiologist, or cardiologist. We receive a question always, what do you want to know about this exam? So about the CCTA, the questions we need to answer are: is there a coronary stenosis? If their stenosis is less than 50% or more than 50%, is there a high-risk plaque? Is the lesion flow limiting? And is the lesion lead to ischemia? And should we intervene or not? CCTA can answer those questions. This is a cartoon of the atherosclerosis, coronary atherosclerosis. And as you know, atherosclerosis is the pathognomonic features of coronary artery disease. But atherosclerosis per se is just a subset of the wide spectrum of the disease that starts even with a normal coronary vessel and progress to inflammatory process and development of a plaque. Such plaque can be high risk in rupture, cause coronary acute coronary syndrome, and then this plaque can develop to and deposit with the calcium deposition and progression of the plaque to encroach on the lumen. And throughout this, the spectrum of the disease, CT can be very helpful from the beginning. CT can depict the luminogram to rule out any disease. It can evaluate the initial step of inflammation in the vessel by evaluation of the perivascular fat index. And then it can add a diagnostic as well as prognostic value for evaluation of the non-calcified high-risk plaque that are liable to rupture and to cause acute coronary syndrome. And now CT is used for evaluation even of acute coronary syndrome. And in cases of a question about the significance of the physiological significance or the ischemia-producing lesion, now we have the technique of CT-FFR, which can evaluate at this point. To start with any test, including the CCT angio, we have to understand what's called the pretest probability. The pretest probability actually is the evaluation of any diagnostic test. And for the CCTA, the pretest probability came from the ESC guidelines, the European Society of Cardiology guidelines, and that give the CCTA class 1 recommendations. It means that it's a highly recommended procedure to use. And that was based on the test probability, the pretest probability. The pretest probability is depending mainly on the likelihood of the presence of the disease. So if the likelihood of the presence of the disease on this side is low, so the test is not needed. We just, the patient's coming with a non-cardiac chest pain, so we discharge the patient home. While on the other side of the spectrum, if the likelihood of the presence of the test is very high, the patient is very high risk, again, the CT is not the proper test. We can proceed with this patient to invasive angiography. But the CT is mainly indicated or required when we have an intermediate test probability. And this intermediate test probability is based on the likelihood of the presence of the disease. So they came with a model that includes patient's age, the presence of chest pain and dyspnea. They added other clinical factors like EKG, the ejection fraction, and the calcium scoring. And they came with a pretest probability that's in which CCTA is indicated in the intermediate to high risk in between the 15 to 50% probability. But the Scott Hart trial, which was a big trial studying the role of cardiac CT in evaluation of coronary artery, they found that when you have the probability less than 5%, the annual risk is 1.4, the annual risk of events. While if you have it over 15%, the annual risk of events is around 4.1% of event rates. Amazing. What can we know about that? That means still even the low risk probability, less than 5%, can cause events over the long term. And we like to describe it in the form of the pyramids of ischemia, or the pyramids of evaluation of ischemia, where at the base of the pyramids, the asymptomatic patients, and here no test needed, we can discharge patients home. While patients at low risk, we can use the simple tests like the EKG or calcium scoring. And then here it comes to the role of CCT angio and the other ischemic tests, the intermediate to high risk, where the CCT angio can roll out mainly the coronary artery disease. The top of the pyramids will be the acute coronary syndrome presentation. And here again, these patients, we're going to refer them directly to the cath lab. And we like to discuss the diagnostic and prognostic role of the CCTA based on what's called the efficacy ladder, or level of efficacy, that include the step-by-step technical efficacy, then diagnostic accuracy, and the therapeutic efficacy, then the patient's outcome efficacy, and then the society efficacy. So first, technical efficacy. You are radiologists. You are excellent knowing the different parameters of the CT. And as you know, like during the last 2 decades, there was a big advancement, a refining of the CT machines. Those are the different vendors of the CT machines, and as you can see, there was a big advancement and refinements of both the collimated detected with the number of detectors and the both temporal and spatial resolution. And now we have the dual source CT machine. We have the ultra high resolution, as you can see, beautiful depiction of the lumen, and we have the photon counting. The ultra high resolution, you can appreciate the difference between the conventional CT image and ultra high resolution CT image, that we can even exclude the calcium or the stent from the image to show a nice luminogram. While the photon counting is the revolutionary technique now, as you know, when we are dealing with the CT, we are dealing with the X-ray in general, we are dealing with arrays. But for the photon counting, now we are dealing with a single photon. Each single photon represents replace the beam of X-ray, so it can give a very nice image, even with the presence of the stent, or with very precisely depict the lumen and the demarcations between the calcium and the calcium here and the lumen of the coronary vessels. And the next step will be the diagnostic efficacy. The diagnostic efficacy of cardiac CT angio mainly comes from its high negative predictive value, high sensitivity, and high negative predictive value. And this table shows the number of studies they conducted over the last 2 decades to confirm the diagnostic accuracy of CCT angio, including the assessment of lesion over than 50%, 50% stenosis, assessment of lesion over than 70% stenosis, even with the presence of atrial fibrillation or irregular heart rate. The performance of CCTA was excellent, was mainly the sensitivity up to, in some studies, up to 100%, and the negative predictive value, specifically the negative predictive value, which ranged between 82 and 99%. That means if the CCTA exclude the lesion, mostly up to 99%, there will not be coronary artery disease if there is no plaque. And there was a number of studies confirmed this idea, including, as you can see here, if we evaluate all patients or including even the non-diagnostic test, still the CCTA has the area under the curve or sensitivity up to 90%, including the subgroup of patients. The CCT angio has there is no big difference, but for some reasons the performance in males is better than females, and also the performance over 75 years is a little bit less than patients with less than 75 years. And if you look at the angina, there was no difference in evaluation of the different types of angina pictures. And again, if we look at the area under the curve at the patient's level or at the vessel level, there was no difference. Even if you, this is the different coronary vessels, whether it is less than or more than 50% stenosis. And if you compare the CT with the other functional tests, you will find that the CCTA performance is overweighting the other, or more than or superior to the other types, and even comparable to cardiac MRI in sensitivity and a little bit less in specificity when you compare that to the other non-invasive anatomical functional tests. And even if we compare the CCTA with other functional tests of ischemia, like SPECT, like PET, and the reference will be FFR, still the sensitivity, mainly the sensitivity of CCTA is superior to the other tests. When it comes to the specificity, it's less than the other tests, but the idea of CCTA is mainly sensitivity and negative predictive value. The second step will be the prognostic efficacy and the clinical outcome. And again, CCTA is excellent in detecting the prognosis of the coronary artery disease. But here I will stop for a second. This slide showed that for the patients referred to us in radiology, in our radiological department, 1 in every 3 patients referred for us will have a coronary artery disease, non-obstructive coronary artery disease. So the non-obstructive coronary artery disease represent almost 30% of patients referred to us. And what is the importance of non-obstructive coronary artery disease? This is a task of the imager, not to detect only the obstructive coronary artery disease, but to detect the non-obstructive coronary artery disease. Because if you look at the difference, the annual event rate, by event rates here, we mean the occurrence of myocardial infarction or cardiac death or revascularization. The annual rate when there is no coronary artery disease is 0.2%. While if there is non-obstructive coronary artery disease, still there is an annual rate 1.6%. That means that sometimes the non-obstructive lesions can be as important as the obstructive lesions. And here, as you see, that if you look at no coronary artery disease or non-obstructive coronary artery disease in red, and the obstructive coronary artery disease in green, you will find that still there is a MACE in death and myocardial infarction and revascularization in presence of non-obstructive coronary artery disease. The other side, the right side of the panel, non-obstructive coronary artery disease is intermediate between in survival, even free survival, and then between the no coronary artery disease and the obstructive coronary artery disease. So that's a very important point in which CT can provide available information about this evaluation. And if you look at that, this is a Scott Hart trial. It's a big trial to investigate the role of CCT angio in evaluation of coronary artery disease. And as you can see, compared to standard of care, CTA was superior to standard of care associated with lower incidence of MACE. And even if we compare the CT to the invasive angiography, you will find that the comparison is in favor of CT. And that also would be applied to the subgroup analysis. So the superiority of CTA over the standard of care. By standard of care, we mean here that the functional tests or the ischemia tests we are using, or the other anatomical tests we are using to evaluate the coronary artery disease. And as you can see in this meta-analysis, CTA was superior to the standard of care regarding patient's age, patient gender, diabetes in all subgroups of patients. And this is the study also confirmed the importance of non-obstructive coronary artery disease. When you have non-obstructive coronary artery disease, you have a hazard ratio still 1.1, while when you have an obstructive coronary artery disease, the hazard ratio is 2.9. So still, the non-obstructive coronary artery disease the prognostic of which can be deleterious. So when you compare the CT angio to the invasive coronary artery, invasive coronary angiography, the performance of CT also is associated with less incidence of MACE, even with the gold standard of diagnosis of coronary artery disease, which is the coronary angiography. Then we have the quantitative and the qualitative assessment of the plaque. That's our meat as a radiologist, is the picture, the image to evaluate. And this is the classification of the Society of Cardiac Computed Tomography of the segments of the coronary arteries, which is similar to we are using in coronary angiography to depict the coronary artery tree, arterial tree, anatomical tree, the left main coronary artery that divided into the LAD and LCX, sometimes the ramus intermediate, and this is the right coronary artery, and ends by the PDA and the PLB, a posterolateral branch or posterolateral ventricular branch. And the first step, we use the CTA in evaluating the plaque is for evaluation of the plaque characteristics, type of the plaque. And as you can see here in this picture, CTA can nicely image the lumen and the plaque, and we correlate that to the pathology also. So this is the lumen, and this is a non-calcified plaque, and associated with a fibrous plaque in the pathology. And this is the picture of the calcified plaque, the image of the calcified plaque, and this is the lumen, and this is the image of partially calcified plaque. You have or mixed plaque. You have calcium and some attenuation here, and this is the lumen. On the other hand, of the other side, the right side of the panel, you have the CT attenuation pattern, whether this plaque is homogeneous around the lumen or heterogeneous, or it is a napkin ring sign, which is a high-risk plaque. Regarding the degree of stenosis, so now CT can give you an idea about the type of the plaque, the characteristics of the plaque, and also here the importance will be the degree of stenosis. As you can see here, the lumen is nicely evaluated. There is no stenosis here. This is the minimal plaque. By minimal plaque, we mean the plaque between 1 and 24% stenosis. Mild is between 25 and 50, and the moderate is between 50 and 70, and severe between over 70 to 99, and this is a complete occlusion. As you can see here, there is no lumen at all. You can't see the lumen in the image. Based on that, we came with what's called CAD-RADS score, or CAD-RADS system, coronary artery disease recording and documentation system, where score of 0 means no stenosis, absence of coronary artery disease. 1 means the stenosis 1 to 24, minimum non-obstructive. 2, 25 to 49. 3, 50 to 69. 4A means the severe stenosis in single or two vessel. 4B means stenosis more than 50% on the left main, or more than 70% in 3 vessels. 5 means total occlusion, and then we have N, CAD-RADS N, means that this segment of the lumen is a non-diagnostic study. We cannot evaluate it. And as you can see here also, they correlate the grades of CAD-RADS, or the classification of this CAD-RADS to the prognostications. So when you have the CAD-RADS 0, no coronary artery disease, or no disease at all, of course the prognosis will be, or the survival probability will be higher than when you have a CAD-RADS 3 or 4. Not only that, but not only the degree of stenosis, but now it's very important. We added the segments the plaque burden, what's called the plaque burden, the segment score, the segment involvement score, that showed that the higher the segments involved in the coronary arteries, the higher the incidence of MACE, and the lower, of course, the survival probability. So if you have the segments more than 5 segments affected, that will be associated with up to 1.3% MACE rate. So that's why we came with the idea or the concept of plaque is a powerful predictor of risk. It's not only the stenosis, but it is the segments involved. So segments involved score, SIS score, as you can see here, if you look at this this figure, you can appreciate this is in orange. This is the non-obstructive plaque, non-obstructive coronary artery disease, but segments of more than 4 segments affected. It's almost have the higher incidence of MACE compared to obstructive coronary artery disease with less than 4 segments. That means the power is not only of the degree of stenosis, but also the amount of the plaque or the extension of the plaque burden. That's why we have a modification now of the CAD-RADS1. We have what's called CAD-RADS2 that describe the amounts of the plaque as mild, moderate, severe, or extensive according to the number of segments affected. So if you have less than 2 segments, it gives P1, and P here refers to the plaque. If you have 3 to 4 segments, it gives P2. 5 to 7, P3, and more than 8 is going to be P4, and we will see some examples for case example for that. And here we add a modifier now, the I. The I indicates ischemia. That's good. They combine the physiological assessment or the ischemia assessment using the CT-FFR, as we'll see in the subsequent slides, to the anatomical features. So I positive means that this plaque is not only encroaching in the lumen, but also reducing the blood flow, saying that's an indicator of ischemia. While I negative, it means that the plaque is not affecting the degree of or encroaching in the lumen, but not to an extent to cause local ischemia. And I positive or negative, it means that it's inconclusive. So the next step will be the importance of CTA in evaluating the high-risk plaque. And by high-risk plaque, we mean the plaque that have a low attenuation plaque, less than 30 Hounsfield unit, or the spotty calcium, and the definition of spotty calcium in coronary arteries are the calcium less than 4 millimeter, and the arc of calcium is less than 90 degree, or the napkin ring site, or the positive remodeling. And we came with this concept by correlating the CCT image to intravascular imaging. Intravascular imaging is the invasive modalities in which we use the ultrasound to via catheter to evaluate what's inside the lumen vessel. So the lumen of the vessel of the coronary artery. So this is the catheter, and this is the plaque in ultrasound or OCT, which is using light laser to evaluate what's inside, and that's correlated to the pathology. If you look at the pathology here, that's an necrotic core and the thin cap of the plaque. So this is the plaque we correlate to in CT, and we call it high-risk plaque. The plaque that has a positive remodeling, which is the dilatation of the vessel at the sides of the plaque that equals 1.1 in relation to the reference segment, and this has a hazard ratio of 11. I'm sorry, a relative risk of 11, and the low attenuation plaque that less than 30 Hounsfield unit, and the relative risk here is 8.2, and the presence of napkin ring sign, this is an alarm of high risk plaque, the relative risk is 8, and with the spotty calcium, the relative risk is 37.2. So the presence of spotty calcium, even with the absence of stenosis, is similar to stenosis more than 100% or even higher. That's 37 relative risk, and this is 34. And when you combine those anatomical high-risk features with the physiological high-risk features, which is called the FFR, that's a measurement of ischemia, you have this the hazard ratio of 11 compared to 1 if you don't have any of this anatomical or physiological high-risk features. Now, CT has an important role in evaluation of atherosclerotic plaque characteristics, and this is the new techniques that developed in the last 5 years from many vendors with many softwares to evaluate the composition of the plaque, what we call the plaque segmentation. And as you can see here from different vendors, they have the softwares to give you the color mapping of what's inside the plaque. So it will give you the red color will be a necrotic core, the white color will be calcium, this yellowish green will be fibrofatty plaque, and the green will be fibrous tissue, and it gives you even the volume of the plaque, the total plaque volume and the volume of each component of the plaque, and the remodeling index as a sign of high-risk plaque. And by using this color map and this volume, you can follow your patients up along, like by subsequent CCTA to see if this color regressed or not, as we will see also later. And one of the FDA-approved software is called Clearly, from a company called Clearly, that's evaluated in a study called Clarify. They collected almost like 1 million CT images, and they did an artificial intelligence, deep learning to teach the machine. That's compared to the expert annotation or segmentation, and they came with the evaluation of the plaque characteristics. As we can see here, those are the steps they are using. Firstly, collecting and the image, and selected two best series of image, and evaluating the central line, then evaluating the plaque characteristics using this color mapping, and the performance was around 95% for stenosis, 50%, and around 99% for stenosis, 70% or more at both patient level and vessel level. So that's actually consolidate now the role of AI-based software in evaluating the plaque characteristics. What about the therapeutic efficacy? The CTA also can help us to modulate treatments. As you can see here, this is the role of CT in modulation of treatment for cardiac patients. That's aspirin before CCTA and after post-CCTA when there is no coronary artery disease. And this is when there is less than 50% stenosis, the CT can also modify the patient's treatment. We can modify the patient's treatment based on CT and give more aspirin. And for patients with more than 50% stenosis, there were 25% before using CT, which increased to 89% after we did the CT, because we saw that it's an extensive disease, it's a high-risk plaque, and so on. And the same thing for statins. We can only modify it, but intensifying the dose of statins, give maximum statins based on the image of CCT and the evaluation of the plaque characteristics. As you can see in this image, and this is the statin-naive patient. Here the patient doesn't take statin, and if you look at this color, this red color indicates a necrotic core, a lipid core. And here, this is the fibrofatty plaque, this yellowish green, and this green is a fibrous tissue. So this patient has a high-risk plaque. With a positive remodeling, this plaque can be is liable to rupture. And look, after we give statin, we have the plaque stabilized. This white color was calcium. The plaque has been confirmed from the rupture-prone plaque, the plaque that's liable to rupture because of this necrotic core and fibroatheroma, to a plaque that has a calcium in it. The calcium gives more stability of the plaque, and because you can see here, even in this picture, the vessel has been changed to a calcified lesion. And then the next step will be the decision making based on CAD-RADS, the role of CT in decision making. And as you can see here, when you have a CAD-RADS 1, this is just minimal stenosis, or CAD-RADS 2, that's a mild stenosis. So we do just risk factor control and secondary prevention. While if you have a CAD-RADS 3, moderate stenosis, usually beside the risk factor modification and secondary prevention, we refer the patients to do CT-FFR, the functional diagnostic tests. When we have CAD-RADS4 diagnosis or stenosis of 70 to 99%, we refer this patients to invasive coronary angiography. When you have even when you have the in-stent restenosis or you have a total occlusion, besides the risk factor modification, we refer the patients to invasive evaluation. The same thing when you have the left main. This is the left main disease has a stenosis more than 50%, or when you have a multiple lesions, this is CAD-RADS4B with the degree of stenosis more than 70%. Besides the risk factor modification, anti-ischemic therapy, and evaluation of left ventricular function, we refer patients to invasive evaluation. So that's the role of CT in management planning, but that's extends even to invasive techniques. Look at this nice image, beautiful image. What they are doing here is a CAPage planning based only on CT. So they did CT angio and they did CT FFR, and they defined the length of the lesion, they defined the areas of stenosis, and the surgeon put a Lima graft over the LAD based only on CTA without doing coronary angiography. That gives you an impression now about the potential and also actually the excellent role in CT, or gives you an idea also about the CT, the lab of the future. What will be the lab of the future? Everything will be based on imaging, non-invasive imaging. Now a hint about the CT FFR, which is actually the modality that adds to anatomical evaluation. So this is a modality to assess a functional evaluation or ischemia evaluation. By FFR is the fractional flow reserve. This technique, we use it in the cath lab using a pressure wire. As you can see here, we pass the pressure wire across the lesion, the stenosis, and we induce, by inducing hyperemia, we give adenosine to induce hyperemia, and we measure the degree of pressure drop across the lesion. And we have here the cut point is 0.8. When we have a significant lesion, you will have an FFR of less than 0.8, while if you have a non-significant lesion, the FFR will be more than 0.8. And actually, simply, it's a ratio between the distal to the lesion and proximal to the lesion, the blood flow and the pressure distal to the lesion and proximal to the lesion. And by using an AI now, we could simulate the coronary tree, and by using what's called deep learning network, we could extract the CT FFR non-invasively without using this pressure wire in the cath lab. We use it now just based on CT image. We use the technique called the CFD, the computational flow dynamics, to measure the flow across the coronary vessels based just only on CT. That's the CT FFR. And based on this CT FFR, we can take the decision. And the CT FFR, we use it mainly when you have an intermediate lesion and non-conclusive, not the high degree stenosis and not the simple lesion. And this is an example of the CT image, how the CT FFR, how it comes. It's like you send the CT image, and it comes back with this nice color mapping, where the red color means this is the area of the highly stenotic area, while the green color means this area or this lesion, this area doesn't have any stenosis, and you can localize the areas in which you're going to put your stent or you need to replace. The CT FFR requires some technical radiological elements that we should use it, where the CT machine should be more than 64 slices, and it needs a very good resolution, because as you can see, the results is depending on the spatial resolution or the good imaging of the. The CT-FFR has been validated against the invasive coronary angiography, and in different studies, including the Pacific trial that showed the performance of CT compared to the invasive FFR. The FFR CT showed the highest diagnostic performance for vessel-specific ischemia, provided coronary CT image were available. And this is, as you can see in this meta-analysis, the performance of CT-FFR. And then finally, the financial efficacy. This is the final step of the ladder, because there is some discussion about the price of CT. But if you look, those are trials that they conducted these trials just mainly to evaluate the CCTFR, the CCTA for the diagnostic and prognostic value, but they add the financial part of it. And if you look in the PROMISE trial, after 3 years, the cost is $7,000 compared to $6,500 for functional testing, non-significant. For the Scott Heart, $1,900 compared to $1,400. But if you exclude the index CTA, there will not be difference. And in Crescent, compared to the stress test, the price was in favor for the CT. So from the financial point, CT can be a cost-effective test. And if you remember the first slide, I was showing about this spectrum of atherosclerosis. We detected the early stages of development of the atherosclerosis, which is in the form of calcium scoring. And here we can do that with some software, AI-based software for automatic calcium scoring, and not only the total calcium scoring, but calcium scoring in each vessel. And you have now correlations between calcium scoring and the estimated annual risk of coronary artery disease or coronary artery disease. So if there is zero calcium scoring, you reassure. Calcium score between 1 and 100, consider statin and aspirin. More than 100, maximize the statins and treat with aspirin. And the other part of the first slide, if you remember, it was about the early detection of inflammation, about the detection of perivascular fat index. And this study they did using an AI-based program, the CRISP study, to evaluate the perivascular fat index, and they found that when you have the higher perivascular fat index, it is associated with the adverse, the all-cause mortality, and at both the patient's level and the vessel level. So that was the comprehensive coverage of the diagnostic and prognostic role of coronary CT angio, and based on that, we came with the guidelines, the 2021 AHA, American Heart Association, American College of Cardiology, and Society of Cardiac Computed Tomography that give CCTA the class 1 recommendations for evaluation of acute chest pain, especially if there is no prior testing. So alternatively to the stress test, and the exercise stress test, and the echo stress test, and the other functional stress test, CCTA now is class 1 recommendation for evaluation of acute chest pain. That's at intermediate or high risk. The very high risk should go to the cath lab. For stable chest pain, also if you have an intermediate or high risk, and the CCTA is class 1 recommendations in patients with stable chest pain and no previous coronary artery disease. And if the test is inconclusive, also CCTA can be a good option for evaluation of the chest pain. For stable chest pain plus no coronary artery disease, and if there is an obstructive coronary artery disease more than 50%, we intensify the medical treatment. And if there is after intensification of medical treatments, if there is a frequent angina, the options will be invasive testing. But if it's non-obstructive with less than 50%, and the insufficient or previous strategies are and options to defer treating, we can use the CT-FFR. The CCTA here is class 2A, and we can use the CCT-FFR to evaluate the intermediate risk between 40 and 90%. With that, I will conclude the first part of the webinar, and as you can see, I can summarize what I said, that CT-FFR now is the modality of choice for evaluating the coronary artery disease, especially to rule out the presence of coronary artery disease, but with a substantial different modalities and techniques that can help us to evaluate the whole spectrum of the coronary artery disease. Thank you so much, and I'll be happy to take any questions.
Thank you, Dr. Dia. Amazing, comprehensive talk. It was very interesting to listen to a clinician, cardiologist, and an interventional cardiologist talking about CT. Thank you very much. Amazing. I wonder if there was any questions from the audience. Let me check. I think we don't have any questions, but I'll ask you about, let me see, no questions yet. So how often, like how clinically validated is CT FFR in your practice?
Well, that's, well, actually, if we are talking about the everyday practice from the clinical point of view, if we have the 20 to 25 cases of CT per day, we have at least 5 to 6. We refer them to a CT-FFR, because the intermediate region is prevalent, and it has been validated against the invasive FFR as it in this meta-analysis. And also the question, that's a great question, because now even the interventional cardiologists, they can say, after the positive CT-FFR, should I do the pressure wire or not? But what I can see in my institutes, we are taking the decision based on CT-FFR, which has been already validated in the trials. Yes. And we see that even at the beginning, the interventional cardiologists were not convinced with the CT-FFR. So they took the patient to the cath lab, and they did after the invasive wire FFR. And they found there is no big difference between them. And now it is almost a standard of care for the intermediate intermediate cases, or the intermediate stenosis between 50 and 70%, moderate stenosis.
Thank you very much. So amazing exhibition of AI techniques in. So out of these, would you say FFR is the most commonly used, or do you use something else?
Well, the FFR, the CT-FFR, but the Clearly program, we are using it in, there is a grant from NIH grant, about $4 million grant, and we're using this Clearly program for plaque analysis, because those softwares now, you can use them for, as I showed, even for AI-based calcium scoring, automatic calcium scoring, not only because this is something very interesting for radiologists, also, not only coronary calcium scoring, but they use it for the automatic calcium scoring for the aorta, the ascending aorta, and the ascending thoracic aorta. And that's all now is AI-based. The perivascular fat index, that we have a software now doing that based on AI, and perivascular fat index not only for the coronaries but for the peripheral vessels, for the segmentation of the chambers, for the evaluation of left ventricular function. So now AI is coming in the different aspects.
I think we have a question. Okay. Do you specify the CAD-RADS for each lesion or for the dominant lesion?
No, for the CAD-RADS, we specify based on the collective evaluation. So if you have, for example, I will show some examples of that to be this example. But if you have a CAD-RADS 0, if you have a CAD-RAD 1 in LAD and you have a CAD-RAD 2 in the circuit, for example, you give a CAD-RAD 2. That's like what's the highest degree of CAD-RAD. So we give the overall CAD-RADs based on the highest degree of CAD-RAD in whatever the vessel. So if the highest degree is moderate, it's going to be moderate. So that's the point. I will give some examples.
Okay. So should we go for the practical cases?
Sure.
I think it's time, yes.
So let me share my screen. Can you see my screen? I'm sorry, I have to return back to this. Excuse me. I think I should share the other one, the one I was, this one, because I think, okay. Can you see my screen?
Yes.
Okay, now we're gonna proceed for a case example. And what I choose actually is one simple, straightforward, the normal case, and then I will explain how to evaluate how to evaluate the case step by step, and then move to share my slides regarding the different pathological examples of what we can see. So that's a video. I did this case, and as you can see, I will start first by we have a reporting system now. We have a documentation from the Society of Cardiac Computed Tomography on how you can evaluate coronary artery disease or CCTA case. So we start your radiologist so that you are perfect in reporting this. So we start with the technical aspect. That's mean the type of the machine we are using, the kV, the amount of contrast, whether we do the prospective acquisition or retrospective acquisition, what is the phases of cardiac cycle, and then the clinical aspects, the patient's complaint, patient's age and gender, and any clinical characteristics, and then we move to the analysis. But here the analysis we start on. This is the multi-planar view. So this is the axial view, the sagittal view, and the coronal view, and we have the crosshair that we can change. And changing the crosshair here, that will change also the crosshair or the cursor in the other the axis in the other views. Here we start for evaluating the coronary arteries. The first step is to look at the origin of the coronary arteries. This is the aorta. This is the left coronary artery. This is the left main. So the left main arising from the left coronary sinus, and the right coronary artery arises from the right coronary sinus. So this is the normal origin of the coronary arteries. So that's the first step. The left arises from the left, and the right arises from the right. And then if we proceed, we will look at the left main. The left main here bifurcating into LAD, this artery that pass anteriorly. For the sake of it, like the illustration, I'm putting the map. the maximum intensity projection, but actually when we are evaluating the vessel, we are using the thinner slice. That's why the resolution was different, because I'm trying to show some illustration. So this is the LED. For each vessel, we have to comment on three things. Firstly, the size of the vessel, whether it is a large size vessel or average size vessel or a small vessel, and the branches, and if there is any plaque or not. So this is the LED, and as you can see, it's an average size vessel. We comment on the LED and we follow the LED, the left anterior descending artery, till the apex. Here, that's, as you can see, so the LED wraps around the apex. If you follow the whole vessel, I'm zooming now and following the vessel along the course and trying to change the axis. So this is the left ventricle. And the LED reaches to the apex. So that's the normal course we need to see for the LED. And now we look at the branches of the LED, how many branches. As you can see here, there will be one diagonal branch, which I will let it go, and it is one diagonal branch coming, and the second diagonal branch comes from here. So the LED is an average size vessel, wraps around the left ventricle, and gives two diagonal branches. As you could see, the LED is clear. There is no stenosis. There is no plaque or stenosis in the LED till the apex, and we can appreciate that in the other views, the coronal and sagittal views. So if we proceed to to see the other branch of the left main, that will be the circumflex, and the circumflex will come from here and pass that way. And again, it's as you can see, we'll appreciate that the circ is coming from, I'm changing the axis to see the circumflex. This is the circumflex artery, the other branch of the left main, and the circumflex gives the obtuse marginal branch. So the circumflex, again, is an average size vessel. That's actually, there is no, as you can see, I'm putting the MEP, the maximum intensity projection, and the lumen of the vessel doesn't show any plaque or stenosis, and the circumflex will give the branch which is called the OM. This is small branch. If you are following me, this is the branch of the circumflex that's passed to the posterior aspect of the left ventricle, and this is the one branch only. So for each vessel, we comment on the size of the vessel, the number of branches, and if there is any stenosis or not. That was for the left artery, and now we move to the right coronary artery. The right coronary artery is here, whereas from the right sinus, and the right coronary artery pass on a different course on the right side of the heart, and this is we have to comment on the I'm sorry, that's me just that's the RCA. So here the RCA arises from the right coronary sinus, and for the sake of time, I'm gonna see the first step of evaluation of the RCA to see the dominance. The dominance means which vessel gives the PDA, the posterior descending branch. This branch, the branch which supplies the inferior surface of the heart, and it comes from the right coronary artery in 85% of cases. And when we see this branch, that means it is a dominant right. The circulation, coronary circulation, is dominant right, and we are following the right coronary artery. I'm changing the axis and following the different segments of the right coronary artery, changing the axis on the axis on the axial view, and following the vessel along the course to see if there is any lesion or stenosis in the vessel. As you can see, I can't see any lesion or stenosis up to the end. This is the RCA bifurcating at the end to PDA and posterolateral ventricular branch till the and zooming and changing the axis. And now I'm just like having a general idea about the two vessels, the left system and the right side, or the right system. There is no plaque or stenosis, as you can see along the course of the two vessels. So now we have, this is CAD-RADS 0. There is no plaque or stenosis in both the coronary arteries. I will proceed to the after the coronary arteries, we need to evaluate the chambers, the cardiac chambers. So we have here is the left atrium, left ventricle, right atrium, right ventricle, and we evaluate each chamber to see if there is any abnormalities, there is any aneurysm, and then we proceed to the valves and then to the major vessels. That's the way. Now I'm changing the axis along the longitudinal axis to get what we call the echo 4-chamber view: left atrium, left ventricle, right atrium, and get the short axis view on the coronal section and the longitudinal view on the sagittal section. Now I'm across the mitral valve and changing the axis to get the measurements. I'm measuring the left atrium now. The left atrium measurements is up to 39. And if I'm looking at the interatrial septum here, this is the left atrium, the right atrium, measuring the left ventricle, and we use the echo measurements. There is no left ventricular dilatation. There is no any aneurysmal dilatation of the left ventricle. There is no thrombus, and measurements of the left ventricle dimensions during diastole when the mitral valve is open. And now I'm measuring the thickness of the cardiac muscle to see if there is the myocardium, to see if there is any left ventricular hypertrophy or not. And now I'm gonna move to the here up and down to see here the short axis view, and this is the 4-chamber view to assess the cardiac the left ventricle from the apex to the base. And now I'm moving to the valves. So this is the aortic valve, and I'm starting at the axial view, putting the crosshair at the aortic valve, and then changing the cross here, or the axis, to be perpendicular to the blood flow on the aortic valve. In the other two views, the sagittal and the sagittal and the coronal. And comment on the cusps. As you can see here, there is a 3 cusps. This is the left coronary cusp, the right coronary cusp, and the non-coronary cusp. So it's a tricuspid aortic valve. I'm measuring the sinuses of Valsalva, measurements from sinus to commissure, from sinus to commissure, from sinus to commissure for the 3 cusps, and the normal measurements is up to 35, 36 plus minus 4. So we have normal measurements of the aortic valve cusps here, of the cusps of the sinus of Valsalva. Now I'm moving to the ascending aorta, and as you can see, I'm going to measure the ascending aorta at the level of the main pulmonary artery. And this is now I'm evaluating the big vessels, or the main vessels. I'm measuring the ascending aorta. This is up to 40 is acceptable. 40, I'm measuring the pulmonary artery. This is up to 28 is acceptable. When it is dilated, there is a pulmonary hypertension possibly. So now from the valves to the main vessels, or to the great vessel. Here I will be back here again to look at to show you there is an important thing to evaluate at the level of the pulmonary artery. This is the main pulmonary artery. This is the left pulmonary branch, and this is the right pulmonary branch. And as you can see here, there is no central pulmonary embolism, and this is a very important thing to comment on for the pulmonary artery, the main pulmonary artery, and the main pulmonary and the branches. And also for the ascending aorta, as you can see, there is no thickening, no calcification, and we did the measurements. So that's now I'm focusing on the mitral valve, As you can see, I'm putting the crosshair or the axe along the 4-chamber view, and give the short axis here also to comment on the mitral valve. And this is the anterior mitral leaflet, and this is the posterior mitral leaflet. I'm commenting on any thickening. There is no thickening or calcification of the mitral valve. And if there is a multi-phase, I didn't have multi-phase here, but I can comment on the contractility of the heart, or the contractility of the left ventricle. So this is the chamber and the vessels. And now we will have, as a radiologist, of course, we can't end the evaluation of the image without evaluation outside the heart. So that's the thoracic view or chest view. So we evaluated firstly the coronary vessels, and now we evaluated the chambers and the valves and the main vessels, or the big vessel, the aorta and the coronary arteries. And here we have to evaluate the chest and any pathology related to the coronaries as a cardiologist. In our institute, the cardiac imager is evaluating the coronary and the cardiac findings, as well as the extracardiac findings, of course, with the help of the radiologist. So we are, as you can comment on the degenerative changes of the vertebrae. If there is any nodules, the most important thing that we are looking at for the lung field here is the nodules, especially the nodules more than 6 millimeter, because this will have a specific follow-up by short intervals, or if there is any consolidation, if there is any basal atelectasis, if there is any pleural effusion, or as we will see in the pathology example, we look at the vertebral column, at the ribs, if there is any gynecomastia or any, and then the part of the abdomen just below the chest. So that's just a simple scratch of the surface about because we need more time and we need extensive time for more detailed evaluation. But now I'm gonna share some pathological examples of what I was. Sorry, it's not that one. I'm gonna share some pathological examples of the conditions I was talking about, deviation from normal. So regarding the origin of the coronary arteries, as I showed you, this is the aorta, this is the left main arising from the left coronary sinus, and this is the right coronary artery arising from the right coronary sinus. What is this is the left main bifurcating into LCX, the circumflex artery, and the LAD. That's the normal variants, but the left main bifurcating into the LAD and the LCX. We can have a trifurcation. This is a very short left main that trifurcating into LAD and ramus intermedius and left circumflex. We can have a absence of the left main. That's one of our cases. Also, all this is my cases, and as you can see here, there is no left main, and both the left coronary artery and the LAD and the LCX originating by separate ostia from the left coronary sinus. Can have an anomalous origin. The right coronary artery, most common is the circumflex, arise from the right coronary artery. It can be the left main arise from the right coronary sinus. It can be the circumflex arise from the left coronary sinus. We can have endless anomalous origin of the coronary vessels, but this is a part of this anomalous, and the most dangerous, of course, will be the left main coronary artery in the interarterial course that's between the pulmonary artery and the aorta, because it can be compressed, especially if it is intramural within the wall of the vessel. And we have to comment on the aneurysmal dilatation. This is an aneurysmal dilatation of the LAD, aneurysmal dilatation of the right coronary artery. How could we know? Because here this is the normal segments and this is the reference. And if you measure the diameter of the vessel, this is 3.6 compared to 6.6. So double the size or the diameter of the vessel. The same thing for the LAD here. And this dilatation, the dangerous part of it is that this aneurysmal dilatation, it can be associated with a thrombus inside. If you can appreciate that, there is a thrombus inside the vessel with this low attenuated mass. Well, this is an example of the CADRADS. To answer the question, CADRADS 0, there is no plaque or stenosis on both the LAD, the LCX, or the RCA. The vessel, the luminogram is clean. This is CADRADS 1, because here is the minimal stenosis, the stenosis, the calcified plaque, and minimal stenosis between 1 and 24, and P1, because we have only one segment of the coronaries are affected. This is CADRADS 1, P3, and this is very important stop here. If you remember what I was talking about the extension of the plaque, here this is CADRADS 1. This is minimal stenosis, a calcified plaque, but minimal stenosis. But look at that. We have more than 5 segments of we have 7 segments actually here. 1, 2, 3, 4, 5, 6, 7 segments of the coronary vessels affected by this minimal stenosis, but still we have to report the extension of the plaque regardless of the degree of stenosis. This is an example of CADRADS 2, moderate stenosis. As you can see, it's taking more than 50% of the lumen with this calcium P2, because we have here around 5 segments we have the little bit in the left main, a little bit in the circ, and then the proximal LAD, and 2 segments on the mid LAD. But here CADRADS, for the sake of the question, because as you can see here, there is a minimal stenosis here, and there is a minimal stenosis here, but there is a moderate stenosis in the LAD, so the overall CADRADS will be CADRADS 2. This is CADRADS 4, because we have here severe stenosis, CADRADS 4A, and P1. Again, we are separating between the CADRADS 1, which is the degree of stenosis, and the extension of the plaque. Here, there is only 1 segment, but this is CADRADS 4A, because it is more than 70%, 70 to 99% stenosis, and affected 1 vessel. While if it is affecting more than 1 vessel with this severe stenosis, multi-vessels, it's 4B. CADRADS 4B with P2 here, because there are multiple segments affected, more than 3 segments affected. When it comes to 4B and P3, 4B here, because we have an affection to the left main. Left main stenosis here more than 50%. So this is CADRADS 4B with the extension of the plaque. And if you look here, that's CADRADS 4B P4, because we have the multiple lesions, severe stenosis in multiple vessels, and P4 because we have more than 7 segments affected, or 8 segments affected by the stenosis. So that's extensive amounts of plaque, but the CADRADS is 4 because of the severity of the plaque. And this is CADRADS non-diagnostic. N here means non-diagnostic P2. So here there is a part of the vessel here there is haziness or the motion artifacts here you cannot evaluate. But this segment we can call it N non-diagnostic, but still there is another lesion here, so we will call it CADRADS 2 based on the part of the lesion that we can diagnose. Here there is a motion artifact, but here there is a moderate stenosis, as you can appreciate in the LAD in the cross section view. So we call that CADRADS N. For the part with the motion artifact that we cannot evaluate, but P2 because it is still there is an involvement of 2 segments, and when there is a stent, as you can see, there is a stenosis inside the stent. So we call that CAD-RADS 4-1 because it's severe stenosis, 4A, I'm sorry, because it's severe stenosis, and P3 because of the extension of the lesion, and S here, this is an identifier related to the stent. When we have a cabbage, we have the identifier of the cabbage, but there is an important thing here. When you have a cabbage and the cabbage is patent, we don't give a CAD-RADS to the occluded vessel. So here, for example, you have a lima over the LAD, and the lima is patent, so you don't give a CAD-RADS based on the occluded vessel. So here, though there is an occluded vessel, you give it a CAD-RADS 0 because the graft is open. Right. So, and just quick examples of the evaluation of the pathology on the other the chambers and the valves. Here is an example of PFO, if you can appreciate that. This is the left atrium, this is the right atrium, and you can see a faint passage of the dye or the contrast between the left atrium and the right atrium. And this is an example, a nice example of the ASD, big ASD. This is the left atrium and the right atrium, and you can see the shunt from left to right. And this is the left atrial appendage thrombus. You can see this low attenuation mass here in the left atrial appendage. This is the left atrial appendage thrombus, and this is a dilated left ventricle when it comes to the measurements of the chambers. This is, as you can see here, the diameter of the left ventricle here in diastole, because the mitral valve is open, is 60 millimeters. So that's the moderately severe dilatation by the echo measurements. The left ventricular hypertrophy, measurements of the thickness of the muscle. And this is an example of concentric left ventricular hypertrophy. And the septal aneurysm, as you can appreciate here, like this is an aneurysmal dilatation of the basal septal. This is a nice example of the apical thrombus, left ventricular apical thrombus. As you can see here, this mass at the left ventricular apex, a low attenuation mass or low attenuated mass at the left ventricular apex in both of the arterial and venous phase. And this is an example of pericardial effusion. All this, if you remember, I'm just walking with you with the coronary vessels and then the cardiac chambers, including the cardiac muscle and the abnormalities of the cardiac muscle, and then we'll proceed to the valve. This is, if you can see, there is a rim of pericardial effusion around here. And then this is aortic measurements. This is an example of the dilatation of the ascending aorta, and this is an example of thickening and calcification of both ascending and descending aorta. And this is an example of dilatation of the pulmonary artery, the main pulmonary artery. This is an example of the, if you can see here, there is a massive, small, low attenuation masses in the peripheral branches of the pulmonary artery. This is an example of bilateral peripheral pulmonary embolism. And then we move to the valves, the abnormalities of the valves. This is the aortic valve calcification, severe calcification over the aortic valve. This is the bicuspid aortic valve. As you can appreciate, there is only two cusps here, fusion of the right and non-coronary cusps, and here is the left coronary cusp. It's an example of the mitral annulus calcification, severe mitral annulus calcification. That's include both the anterior and posterior mitral valve leaflets. And then as a radiologist, this is an example of the pulmonary nodule and the lung field that requires follow-up. This is the bilateral pleural effusion. That's the components of the extracardiac we have to comment on in our test. This is an example of pleural effusion and in pulmonary edema, and also the part of the abdomen which is related to the heart, and an example of the hiatal hernia and esophageal thickness. So by that, I'm concluding the as you know, it's a big, very big topic, but I hope that I could just scratch the surface, giving you an rapid idea about how to evaluate a case and some example of the pathological pathological features we can see in both the cardiac chambers and outside the heart. And I will be happy to answer any question. Thank you so much.
Thank you so much, Dr. Dia. Amazing cases. And I noticed that you are using the update of CADRAD 2.
Yes.
Yeah. Did you find it useful to transition to or easy? Tell us your experience.
Well, I have to say that Ron Blankiston was the one who was like created the CADRAD 2. He's in our institute, and actually at the beginning, totally agree. At the beginning, we had some, we were a little bit not very familiar with that, and we had this post beside the computer to count the cases and see this is the P1 or P2 or whatever, and then a big discussion. But now, as you work with it becomes a standard of care. That's after the CADRAD 1, we add the number of segments. As you could see, it's easy. It's simple to count the number of segments affected. But yes, the answer is yes. It's a part of our report now. To have the final comments will be first the total of the. For the sake of time, I didn't show the report, but the report now includes the impression. That's firstly the total amount of plaque, the CADRADs first, and the total amount of plaque in a separate category in the report, and then the overall impression, and then the final decision. What would be the final decision? So we have the first line will be CADRADs 2, for example, P1, and we will comment in the general impression saying, for example, moderate amounts of coronary plaque leads to moderate stenosis, CADRAD 1, and in the parentheses the degree of stenosis and the degree of segment involvement, and then the decision would be like refer to coronary angiography or medical treatment or whatever. So it is part of our report now.
Reporting, yes, I agree, totally agree. We have a question from the audience. What is the normal measurement for LV, RV, RA, LA diameters?
Sure. Well, we for CT we are using the echo measurements. So, like, our reference is the echo measurement. So for the LA, for example, anything over 39 or 40, that's considered the abnormal. So starting from mild dilatation up to 50, 55, and then like moderate over that, and over 65, this is the severe dilatation. The same thing for LV. For the right side, we don't have a very precise measurements even for the echo. So we do visual evaluation or visual estimation compared to the left side. For the
and this is in axial.
Exactly. We measure mainly for the. If you remember what I was doing, if I had more time, I would do it in details. We put the axe at the level of the mitral valve, and we at the axial level to get the 4-chamber view, and we change the axe to get and we measure in the 4-chamber view, and we can measure during diastole, mainly when the mitral valve is open.
Okay.
And you saw me measuring even the thickness of the myocardium, and we use the reference of the echocardiography, which is up to 10 millimeter. Over that, we're going to be left ventricular hypertrophy.
We have a few more questions actually from the audience. Third question is regarding CT-FFR. Can be activated on Philips workstation? Do you have an idea?
Well, the FFR is, there are, the company that had the FDA approval for CT-FFR, it's called HeartFlow. So the basis of CT-FFR is that you take the CT image, regardless of the machine, Philips or Siemens but it should be over 64 slices.
Yes.
Must be over 64 slices with a good resolution. And you send the image to the company, and the company will do the analysis and send you the report. So the CTFFR is not related to the type of the machine or the vendor, but it
It's a
should
separate,
must be more than 64 slots.
Okay, good. Fourth question.
Please.
What about late iodine enhancement? Do you
Yes,
do you use
for
it?
the
Yeah.
I showed cases of the coronaries only, but for we have some patients referred for evaluation of left atrial thrombus or left atrial appendage thrombus. So we are doing late iodine enhancement in all the cases. So we have the arterial phase and we have the late phase, which we do that 6 seconds after the initial acquisition, because if you see one of the examples, I'm sorry for the sake of time, I was like running. One of the examples I showed the left ventricular thrombus. It was during the arterial phase and the delayed phase. And
I
also,
think, but what about delayed myocardial enhancements using CT?
We are doing it. We have what's called the mosaic protocol. I'm sorry, the music protocol that will show the delayed enhancement with a certain parameters. We are doing it, and we can detect that. Of course, the MRI is superior. The delayed enhancement. That's the test of choice to do. But for CT, we are doing cases precisely for to look at the thinning of the myocardium for the late enhancement. But this is a difficult protocol. I'm sorry, a different protocol from the coronary acquisition that requires like.
So it's not like a routine
No,
requirement. Yes.
If I can say, we have like, for example, like 25, 30 patients per day. So like we have, would say 5, 6 calcium scoring and then 15 coronaries. And then we have sometimes requests specifically for late enhancement or for pulmonary valve evaluation before ablation. We have some cases for structural evaluation of the valve for TAVR, mitral or aortic replacement, but it's not a routine. What we are doing routinely, if we have the multi-phase, we do the cardiac function. So this, if you do the acquisition between 30% and the 80%, you can assist the cardiac function. But for the specifically for the late enhancement, we have the what's called the music protocol, which is for specific cases. Like, for example, patients with previous myocardial infarction, and we want to evaluate or suspected scar. But for during the daily cases, we are not doing that routine.
Yes, it has to be a specific request.
Yeah, unless like you can, if you while you are evaluating the left ventricle, if you see some thinning in this phase, which will not be as precise as doing the late enhancement, but you can think about it and say there is a possible thinning of cardium here, but that's required a specific test. We are noting it routinely for each case.
Okay, clear. We have a fifth question. How to calculate calcium score manually using a Gaston score?
Yeah, well, now we have both the manual and the AI. We can arrange for another webinar for calcium scoring, but you can do that like it should be a thick slice, 3 millimeter, and the machine itself gives you the options to pick the vessel, of which vessel we're going to use, and then you click on the calcium. It will delineate the calcium with a different color. So it will give, as I showed in one of the slides, if you remember the slide I showed, it will give. So that was an example of an AI-based AI-based calcium scoring. It will give this color automatically once you upload the image. But for the manual calculation, you upload the image, which will be of course the acquisition of calcium scoring. We are not doing that routinely, by the way, before each case, but we are doing it also for specific requests. And that, as I said, that should be like a thick slice, and we click on the item. It will give us the calcium in colors. For the LED, it will be red color. For the manually, you can trace that.
Yes, we can trace it. Yeah.
Yeah, once you activate the option of calcium scoring, it will help you to trace it. And once you click on it, it will demarcate the calcium, and it will give the calculation of ounce field unit for a Gutstone score for each vessel, and it will give you finally the collective Gutstone for the 3 vessels.
But it's always like a dedicated software for calcium scoring. It's not like manual, yeah.
No, it is a part of the software. Like the software I was showing, it's called Visage, the one we are using now. That's the reading software. It's not. You can read any image, but for this software I was showing in the video, there is an option or a click. When you click on it, it can
Yes.
upload the calcium score. So it's not a separate package. It is including within the same software.
I think
I was focusing mainly this time on the chronometers because like the calcium scoring is another topic.
I think it's a very clear answer. Thank you so much. Do we have time, asking the organizer, do you have time for one more question? Sources. Okay, so we have 3 more questions. What resources do you recommend for novice starting cardiac imaging?
For specifically for CT, I would recommend the guidelines. The Society of Cardiac Computed Tomography guidelines. They have an extensive resources in how to evaluate the coronaries, how to do functional assessments, perfusion, evaluation of the valves, of the TAVR, of the mitral.
All guidelines, yes.
Yeah,
it's a good place to start. Yes.
Right, and there is a European board, and there is a board from the CCTA, from the Society of Cardiac Computed Tomography. They have resources, but I think that the guidelines will be more than enough because the guidelines are written. That's the point. The Society of Cardiac Computed Tomography in US is a society that includes both cardiologists and radiologists. So they are working together on the guidelines to give an extensive information for the imager. They call it the imager, whatever, like whoever the imager will be, whether a cardiologist or so I would recommend the guidelines.
That's a good advice, I think. Second question is how to calculate calcium score. No, not this one, sorry. Yeah. What is the cutoff of calcium score above which you do not inject the contrast?
Well, if you are talking about evaluation of the coronaries, I think we have a grading of calcium scoring, but starting from 400 with the new machine, as you saw that, with the photon counting and even the ultra high resolution, now we have what's called the Sure option, which is like it's subtracting the calcium from the image. So whatever the amount of calcium with the new technology, you can still measure you can still do this. But if you are talking about on the level of, like our countries in the Middle East, not all the countries have, and not all the centers, even in US, so calcium scoring over 400 will be like difficult to evaluate the coronary arteries, and over 1,000, of course, it's going to be non-diagnostic.
Yes, I agree with you. Last question. Can you explain milking in case of coronary bridging?
Sure.
Milking.
Milking means muscle bridge. So, like, I have to show some cases. So when you have a muscle bridge, that means during contraction, during systole, the vessel is compressed. And during diastole, the vessel is expanded. This is milking. And that's because part of the vessel is diving on the myocardium. So the vessel is like anatomically is on the surface of it's an epicardial vessel. So it's mainly on the surface of the muscle. But when the vessel dives on the myocardial, that's what we call the muscle bridge. or intramural parts or intramural segments of the artery, or milking. Milking happening when you see this, and you can see that nicely in CT. CT can show that. And when you have a muscle bridge, you have to measure the length and the distance of diving of the vessel. But this is a nice question. But milking means the compression of the intramural part of the vessel or the muscle bridge when it is inside the myocardium.
So it's a descriptive term.
Yeah, so it's mainly, we don't use this term in imaging. It's a physiological term, and it describes mainly the compression of the vessel, of the coronary vessels during systole, but we use the term muscle bridge or intramural intramural segments of the artery.
Yes. I don't think we have any further question. Thank you very much, Dr. Zia. That was a really good dose of coronary CT tonight. And I'll leave the mic for Dr. Lamia to close.
Thank you so much, Dr. Dia, for this comprehensive overview on coronary and specifically on cardiac imaging and specifically coronary imaging. And I'd like to thank Dr. Tomadur as well for her help and for moderating the session. And we look forward for future lectures. I'm sure everybody would like to learn more about cardiac imaging.
That's my pleasure. It was actually my pleasure. Thank you so much. And thank you, Dr. Lamia. Thank you, Dr. Tomadur. Actually, I enjoyed this webinar, and thanks for Icon for the nice organization. I appreciate it, and I'm looking forward to more activities and more cooperation between us. It's my pleasure. I will be happy always to be with you.
Thank you so much. It's our pleasure, and I would like to thank our attendees, and I hope to see them all in our future webinars. And I would like to thank ICOM, the whole group, for their help and for organizing the webinar. Thank you.
Thank you so much, and see you in person soon.
Thank you. Have a good night.
Bye.